Good afternoon, Cape. Cape Grand Rounds on a Friday afternoon. I couldn't be happier to be here. And for those of you who know me, you know that I love zebras and you know that I love hunting for zebras. I'm going to make a disclosure, which is I have been hunting for acute porphyria for a long time. It's a rare disease. The question is, it's also rarely diagnosed. And I think what we want to do today is give you the tools so that we can move to the next element. Now, next slide. We're going to start today really about what's important about being privileged to educate. And I want to acknowledge and pay respect to the many First Nations and Inuit and Métis people in traditional territories where we live, work, and play, which is all across this big country. And as we gather here today, we acknowledge the traditional territory of many nations, included not just the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat, but we are now home to many diverse First Nations, Inuit, and Métis people, and we pay respect to the First Nations, Métis ancestors in this place to reaffirm our relationship with one another. This meeting place is home to many Indigenous people from Turtle Island, and I'm grateful to have the opportunity to share this stage today. Now, who am I? I think most people know who I am. I'm a professor of emergency medicine at the University Health Network. I apologize for that lengthy slide, so we can skip it. You all know who I am. And I think what's cool about today is we're not just trying to screw you up on a Friday, is that today is Rare Disease Day. Tomorrow could have been a rare day if it was a leap year, but it's not. But Rare Disease Day is a day to highlight diseases. And I always say, if you want to be an average emergency physician, it's very easy to be average. If you want to be an excellent emergency physician, you kind of have to know some of these rare diseases. Whether you like it or not, to be a good emergency physician, you have to be a good internist. And we all know that. And today is going to be a day of celebrating that knowledge and celebrating Rare Disease Day. Now, I don't really have any disclosures from industry or anything like that, but I am receiving an honorarium for this program. Dr. Khandelwal is also receiving an honorarium, and she works for Canadian Blood Service. So I don't even know if that's an honor, a conflict, but I think she's a hematologist and probably needs to. Dr. Scott also receiving an honorarium for being part of this amazing panel, and he receives a few other industry sponsored stuff, what he's declared. But I think the key is that this program has received support from Recordati, but really from what we're discussing here, we are not trying to make any recommendations that are pharmaceutically based. We're trying to do what we always do and mitigate potential bias. And we've really done our best to ensure that there's no industry involvement and complying with both the College of Family Physicians and the Royal College to make it that we are providing education that is clean and free and super helpful. Who are our faculty? You know who I am. Dr. Aditi Khandelwal. We have two amazing hematologists. She's a hematologist she works at Canadian Blood Services and she works at St. Michael's. It seems like the most amazing emergency hematologists are at St. Michael's. I'm on Twitter and I feel like all these super people, St. Mike's is a powerhouse for hematology. Our next presenter is Dr. Michael Scott, who also is a hematologist at St. Michael's, and he has an interest in these sort of things. And they both are interested in porphyria and they work at this powerhouse at St. Michael's Hospital. I think one of the things that helps us get better is to realize is that we are going to have times where we poll the audience. So this is a time for you to go onto menti.com. We'll leave that up for a few seconds so that people can capture this or use the QR code so that when they're polled in the audience, they know where to go. So another 10 seconds on that. And that way, this makes this more interactive. And if you put questions, I will be moderating and look at this because the question I have for Michael and Aditi is, how is this really relevant to us? And how are they going to do that? And I can't wait. So let's go to the next slide. So porphyria. Well, you know, when I was a resident, we learned about the WAP triad of weakness, abdo pain, and psychosis. We see a lot of abdo pain. I mean, we see it every day. How many times do you people someone that starts with nausea, vomiting, fainted? How many times you see people who might have a diagnosis of IBS or endometriosis or subcyclical abdominal pain that they've been worked up and down, and no one has a clue. And the patient comes in, and he or she, and it's more she's than he's, they come in annoyed because no one can get their diagnosis, and they're here often, and you might be annoyed by them. And you might have missed the opportunity to make a brilliant diagnosis. And that's what today is going to be about. It's going to be about planting a seed so that when someone comes in with cyclical abdominal pain, they feel weak. Maybe they have objective weakness. Maybe they have paresthesias. Maybe they're agitated. Maybe they're confused. Maybe they're psychotic. When are you going to pull the trigger about phoning a friend and ordering the right tests? So why don't we start with what we want to do here? So we want to recognize acute hepatic porphyria. We're not talking about PCT today, the cutaneous form. We want to talk about that AHP comes to the emerge, and you need to recognize it, and you need to diagnose this. Now, the key thing is you're not going to get the answer in the emerge. You're going to send out the test so that someone's going to get all that credit. And they're going to say, you were diagnosed with porphyria, but it's going to come from us if we make that diagnosis. And we want to talk about how to manage the acute symptoms, because it's not Maxaran, Toradol, and hydromorphone. There's a few other things that obviously are unique to this hematological problem that we aren't people that who have been making this diagnosis. And obviously by suspecting it, by maybe initiating treatment or consultation, we will provide clear instructions for when patients need to be admitted, when they need to return, and get them the follow-up they need. So they're seen by someone smart, like Michael or Aditi. So let's review a case, right? How many of you have seen someone with abdominal pain? How many of you have seen someone with abdominal pain on your last shift? Like, we're at 100% here. And their past medical history could be like something you don't even, like colonic dysmotility. It sounds like they got that from a naturopath maybe, right? Like some GI complaint that no one knows what it is, and maybe it's IBS, and they keep coming back. So you're like, what the heck? They have hypertension, and you kind of ask them about their abdominal pain. And I mean, at some point, which is crazy, one point someone even put an NG to put in some PEG, like whoever does that. And they're seeing a advanced practice provider. They're seeing a healthcare team member who said, you know what, maybe try low carbohydrates. Maybe you're just a little overweight and it's worsening your liver, and it's your fatty liver, and it's worsening all these other things. Maybe that will help. So you order some blood work because, hey, someone comes in, and usually before the nurses, you've even seen them, the nurses ordered stuff. Their hemoglobin's 110, but you're like, 42-year-old female menstruating, that's pretty normal. I know the hematologists are bothered. There's no MCV, but let's assume it's a little low. Their white count's 12, which for emerge docs, we don't care about that. Sodium's 133, who cares? She's probably just been constipated. Maybe she's dehydrated. ALT, not so bad. Everything looks okay. 171/93, hypertension, who cares? Like, that's not emergency medicine hypertension, right? We don't really care about that. She probably was just uptight at triage, a little tacky. But her abdomen's not that exciting. And her meds aren't that exciting. And she's not that exciting because she always comes in. And I don't even know what to do with her. Have you ever seen a case like this? Come on. We see this every day. I don't know what the survey poll says, but I'm going to tell you, I see this every day. On every shift, I come see someone who has cyclical or chronic abdominal pain that no one has made the diagnosis. Yeah, 100%, all the time. So what's the next step? What are we going to do? What is acute hepatic porphyria? And I think I'm going to pass on the mic to someone who knows a hell of a lot more than me, and that's Dr. Michael Scott.
Here we go. Can everyone hear me okay? I think, okay, good. Hi, everyone. Thanks so much for participating in this today. Before I became a hematologist, and even after I started my hematology training, this is often the reaction that both I have seen, or probably done, and also seen when talking about porphyria. It's kind of an anxiety-provoking diagnosis, and sometimes is almost treated like it's kind of like a mythical entity because it's rare and kind of shows up on esoteric differentials, but not something that a lot of people have actually seen in clinical practice. We're hoping to demystify that today. So porphyria, I'm sure aware, is it's a genetic disease, a metabolic disease. It kind of straddles disciplines a little bit. Like we're both hematologists, Aditi and I, but it's also managed by hepatologists, neurologists, gastroenterologists, psychiatrists, metabolic doctors, like geneticists, because it does really straddle this, disciplines and have kind of a multi-system presentation. But basically, fundamentally, it's related to there's some kind of defect in the heme biosynthesis pathway that leads to an accumulation of toxic heme precursors that shouldn't be accumulating, and those cause end organ damage and the clinical manifestations of the disease. Next slide. Great, thank you. So this is we couldn't get through a talk on porphyria without showing the heme biosynthesis pathway, but I promise we will keep this high level and clinically relevant. This is a pathway here, and I'm really showing it to emphasize the point that porphyria is not a single disease. Really, there are 8 different types of porphyria, each one corresponding to a defect in a different step of the heme biosynthesis pathway. Heme synthesis occurs in 2 places, either the bone marrow, about 80%, or the liver, about 20%. We're going to be focusing for the remainder of today on acute hepatic porphyria, so those that are involving heme synthesis in the liver. Yep, next slide. So this is just, again, we're going to be focusing on acute hepatic porphyrias, but this is just to clarify some terminology. So the one useful way to conceptualize porphyria is to split it into the acute hepatic porphyrias versus the photocutaneous porphyrias. For the acute hepatic porphyrias, they're listed there, but the most common one by far is acute intermittent porphyria, or AIP. It's also variegate and hereditary copperal porphyria. They put a little asterisk beside those because those can sometimes have skin manifestations as well, but their predominant symptomatology is the acute hepatic, acute pain symptomatology, which we'll talk about on a subsequent slide in more detail. The aminolevulinic acid dehydratase, I can't even say it, deficiency porphyria is exceedingly rare case report level. Photocutaneous porphyrias, as the name suggests, present more with skin photosensitivity, painful lesions, not really an emergency medicine kind of situation or diagnosis. So we're going to really be focusing on the acute hepatic porphyrias today. This is just showing this very briefly. So this is showing just another way of thinking about porphyria in terms of where synthesis is happening, the heme, either in the mitochondria or cytoplasm. I'm not going to go into that in huge detail. But suffice to say that because of where the defect is in the pathway for all of these, 2 metabolites are going to be high in all of them. So ALA, that's the very first precursor, and PBG, which is the second precursor. So this will come back when we talk about testing for the disease. Yeah, that's fine. So how does this actually manifest clinically? Because this is what's really important. Well, it's thought that the ALA and the PBG, probably more so the ALA, are neurotoxic. So really, we think anyway, we're still learning more about porphyria, but we think that most of the clinical symptoms come from the neurotoxic properties of ALA. So this leads to the classic acute neurovisceral attacks. The hallmark symptom is abdominal pain, which of course, as David said at the beginning, something very common non-specific symptom, which leads to kind of the challenge and frustration in diagnosing. One of the things, and again, this is still common, but one of the things that really kind of should get you thinking, could this be porphyria, is Someone who really seems to have really severe abdominal pain that kind of seems out of proportion. I guess like thinking back to my earlier in training, like kind of like what you're taught with like ischemic bowel, like kind of they have pain out of keeping with the exam. Similar to that, like the exam is going to be the abdomen is going to be soft. There aren't going to be any peritonitic findings. Imaging is going to be pretty normal. That can kind of should make you at least think of the diagnosis. And of course, because of this, it often gets misdiagnosed as a functional disorder. The reddish-brown urine is frequently reported in textbooks. Like patients, it is a real thing. Patients can have it from the heme being excreted in the urine, but it's not a consistent finding. One important, oh, sorry, if you just go back really quick, the triggers of the disease. So this might be what's causing the patient to present in your emergency department. Timing related to menstrual cycle thought to be from the influence of progesterone. Starvation, particularly low carbohydrate diet, as this our clinical vignette was, alcohol, and then medications. Yeah, next slide. So a little more in depth in the symptoms. So neurovisceral, so the neuro. These are not seen in all patients, but you can have acute neurologic attacks, either peripheral or central nervous system manifested. This can include sensory loss, muscle weakness, sometimes almost like a Guillain-Barré type picture. Sweating, dysautonomic features like blood tachycardia or blood pressure dysregulation. Psychiatric disturbances, they can occur. They're not the most common symptom, so it's a minority of patients that have it, but definitely can occur. And then seizures is kind of the last or end stage symptom that is what can be fatal if the disease isn't treated in time. Visceral is more abdominal pain. Constipation is super, super common. Abdomen distension, nausea, vomiting, and then sometimes non-GI pain, so extremity, neck, chest, and back pain. Next slide, great. So because these symptoms are non-specific and common, it becomes a very challenging diagnosis to make. On average, and on the average patient with acute hepatic porphyria took 15 years to have that diagnosis made. Most are hospitalized before a diagnosis is made. So many patients undergo surgeries that are not needed for like endometriosis or their gallbladder is removed, their appendix is removed before the diagnosis is made. And over time, this disease can cause chronic impairment as well. So not only does it cause acute attacks, but it can cause long-term disability. So by making the diagnosis, you could be setting that patient up to really get on a different pathway in terms of their life and getting treatment and preventing that disability over the years. This is just showing kind of the common misdiagnoses that are attributed to porphyria. So non-specific abdominal pain, IBS, depression, fibromyalgia, stress, kind of things you would think about. Endometriosis there too. So when to suspect it? Basically, the pairing is this severe, diffuse, poorly localized, non-specific abdominal pain with a relatively normal physical exam, and at least one other symptom group. So either peripheral nervous system symptom, central nervous system symptom, an autonomic nervous system symptom. And then sometimes they can have these skin lesions on sun-exposed areas worth asking about because remember, two of the acute hepatic porphyrias, variegate and HCP, can have that manifestation as well. Red flags that kind of should also raise your suspicion: recurrent abdominal pain with quote unquote normal tests or mildly abnormal tests and no specific diagnosis, multiple exploratory laparotomies without a diagnosis, a co-occurrence with menstrual cycles or a menstrual related pattern. This weakness, Guillain-Barré mimic, and then some patients, I didn't mention this earlier, but can present with a press-like symptom or syndrome, sorry. Next slide. So revisiting our case. So there's a lot here, and this is a real case. This is someone in my practice, and she gave permission for her case to be shared for education purposes. She has this label of colonic dysmotility. So she had many ED visits with abdomen pain and constipation and got this diagnostic label at some point. She was following a low carbohydrate diet, so this was probably her trigger. She was like an Atkins type diet, trying to lose weight. Mildly anemic, that could be iron deficiency, as David pointed out. Mild hyponatremia as well. And then you see this hypertension and tachycardia. So all kind of fitting, of course, hindsight's 2020. So we're going to talk about now the diagnostic evaluation, but these are, I'm curious to see what test you would order next at this point. Oh, it seems like the answer got shown before. Okay, some for 24-hour urine collection. Okay, well, sorry, the answer is actually on that's check mark kind of popped up. So that's actually the answer. So it's a spot random urine for PBG ALA. So this pet peeve of mine, this plasma porphyrin screen, at least that's what it's called at UHN. Some places call it a porphyrin scan, but it's kind of a misnomer. That's not actually a screening test. That's used to look for abnormal porphyrin precursors in the blood, and it's not a screening test. It's a second line test for classifying the type of porphyria after the porphyria has been made. 24-hour urine collection could give you the diagnosis, but not practical in the emergency room setting, and also is not necessary. You can genetic testing is not first line; it's also a second or third line test to classify once a porphyria diagnosis has been made. So the correct answer is a spot urine for PBG and ALA. So those two metabolites that are at the top of the pathway are in the urine. Highly sensitive for a diagnosis of hepatic porphyria is just to do a spot urine for these tests. And this test should be available at different emergency departments. So random urine sample, there are some, oh, sorry, this is Aditi's section. I'm going to hand it over to her at this point.
All right, thank you, Mike. So we are ready to identify the constellation of symptoms. Maybe in the back of our minds, something's going off here. Perhaps there's some sort of a syndromic association being made with symptoms occurring recurrently after puberty, female patient potentially menstrual cycle-related symptoms, many previous investigations and no answer, and perhaps this is your chance to diagnose porphyria. So porphyria is annoyingly easy to diagnose and hard at the same time. The hard piece is the logistics. So all you need is one random urine sample. But here is the challenge. Porphyrins, or those precursors in the heme pathway, are all sensitive to light. To some degree, they're also sensitive to temperature. Hence, the sample actually needs to be collected in a specific urine container that has sodium carbonate in it. And the best way to obtain a container with a brown bag to protect it from light is to call up your biochemistry lab so they can send it to you, both a bag and the right urine container. The other challenge is once the sample is collected, it should not sit around. It needs to be sent back to the lab so it's refrigerated as soon as possible, because the moment you collect the sample, the porphyrins in the sample will start degrading. And that's actually the biggest challenge in getting enough of a level to clinch that diagnosis. Next slide, please. So false normal porphyrin screens are seen in retrospect for our patients that get eventually referred to us with a diagnosis. And that happens usually because the sample was incorrectly stored or tested. So if you're ever in doubt, even if you see a screen done, if you're ever in doubt and you just think that this might be on the table as a diagnosis, please test it again. There's an opportunity here to change somebody's life. So I feel like this is one of those situations where you have to trust your gut and try again if you haven't seen it before. So here's what happened to Mike's patient, who was a 42-year-old. She ended up being admitted to the hospital, and received an aggressive bowel regimen for the constipation. The internist who was managing her suspected that perhaps this is porphyria, and they sent the lab test, and the patient was actually diagnosed. And on the right-hand side is the sort of results we get from a lab test, where a random sample will have comparison of ALA to creatinine or PBG to creatinine, as well as the creatinine random. That'll show you an elevation. This patient had a quite significant ALA elevation, and the PBG was so high that they couldn't calculate a ratio. The creatinine is also listed there, but that's just part of the ratio. It's not part of actually one of the porphyrin, the heme biosynthetic pathway precursors. This person did go on to have genetic testing, which is not required to make a diagnosis. It turns out they do have a mutation that is consistent with AIP. Next slide, please. So let's say you have a person and you are suspicious enough of porphyria that you want to send a random urine sample. The priority in this situation is to try and stop an acute attack. Porphyrin screening can take a while to come back. It is unlikely that you're actually going to see the result of that random urine sample before the end of your shift. So if your clinical assessment and thought process is that this is something that we need to consider, then the next part of the pathway is to look at a couple of different laboratory parameters that will help determine whether this person is having something that is mild or something that could be classified as moderate to severe in terms of an acute porphyria attack. At the same time, you'll be managing their symptoms. And in porphyria specifically, there are multiple medications that cannot be used because they will exacerbate porphyria. I have listed under supportive care a few medications that are safe to use in a porphyria patient. And there are very good resources that I'll show you on the next slide that can be pulled up just in time to be able to review whether certain medications are safe or unsafe. Those are the same resources that you can use to identify potential drug-related triggers. In these situations where you're thinking about porphyria, it's really the PBG elevation that we're looking for. And even patients who have a previous diagnosis, they may have a PBG elevation at that time. The other lab tests that we're interested in include electrolytes such as sodium, cardiac markers, especially because a cardiac event can be both a trigger or a consequence of a severe porphyria attack. Glucose, because the mainstay of treatment up front is going to be dextrose. And then other testing for looking for other precipitating factors. For every individual where you're thinking about an acute porphyria attack, and while there's consideration made or consultation made about hemin, the first go-to is actually carbohydrate loading. So what we do is we start a D10W IV, and you want to aim for at least 300 grams per day in the dextrose loading. And this actually does help inhibit ALAS for the first enzyme, and then decrease the amount of precursors being produced that are causing these symptoms. So people are expected to respond to infusion with carbohydrate loading fairly quickly, within hours. If there is a suspicion that this person is acutely ill or displaying one of those red flags, like presenting with polyneuropathy or GBS-like symptoms, or perhaps there's decreased LFE or changed mentation, weakness of the diaphragm that you might be worried about, and this is somebody who may need hemin, this is where folks like me would appreciate a phone call, because we can help make this happen. If you were to contact your local blood bank or your local hematologist, we'll be able to help you get access to the mainstay of treatment, which is hemin. Hemin given at 3 to 4 milligrams per kilogram per day for 4 days is the usual treatment. And we'll speak more about that in the next slide. So we'll go to first the drug screening slide next. So here is a mobile-friendly resource called porphyriadrugs.com. I often go to that one on my phone and on On a bigger screen, drugsporphyria.net displays really well which drugs may be safe or may cause a porphyria attack. Next slide, please. Hemin or panhematin is intravenous heme. It takes advantage of the fact that heme will stop further production of heme. And it is a purified human blood product. It is very helpful the earlier it is given. The challenge being that the heme precursors are doing ongoing damage to axons in particular. And that toxicity, although axons take a long time to grow back, we can prevent further harm. We can probably not reverse the permanent damage that has been done to some of the neurons, especially leading to chronic pain in some of our patients, but we can prevent further harm for our patients. Hemin can be accessible anywhere across the country outside of Quebec by calling your local Canadian Blood Services Distribution Center, or your blood bank will help you do that. And for physicians like myself who are on that receiving end of perhaps getting some of these calls after hours that somebody needs hemin emergently, we will help you procure this drug as soon as possible. Now, at this point, you probably also have one of your consultants, either internists or hematologists involved as well, and we will work with them as well to get that drug to you. Next slide, please. Hemin is given, as I said, as a 3 to 4 gram dosage. It is a lyophilized product, and it should only be reconstituted immediately prior to use, because again, just like the precursors, heme will break down with light exposure. I've given you some information there about infusion. I think this is less important. More importantly, we need access. Phlebitis is one of the more common side effects of hemin administration. So while we're waiting for hemin to be procured, usually we need a good large bore IV or a central line to be able to give it. The other common side effects we see with hemin are fever and headaches, and in a small percentage of people, a rash. The other thing to be aware of is vials stoppers contain latex. So if an individual has a latex allergy, this is a product you have to be wary of. Lastly, something to discuss with your hematologist or internist colleagues is if a procedure is required or the person's already on anticoagulants and bleeding, temporarily, hemin can actually have an anticoagulant effect. This is a really esoteric piece of information that most hematologists are not aware of. So this is something having at the back of your mind in case there is a procedure being done on a patient with porphyria receiving hemin. Next slide, please. All right, so these red flags that are listed here are the same red flags that will classify somebody from a mild porphyria attack to a moderate to severe attack. And these include in the neurovisceral category weakness, confusion, agitation, autonomic lability, like that was seen in Mike's patient, is very important to recognize. Pain that is not responding to initial management, and nausea that will prevent somebody from taking glucose by mouth is definitely something to be aware of, and we won't be able to manage them at home. Presence of hyponatremia. You know, we're used to seeing hyponatremia. Which internal medicine patient does not have hyponatremia? But here is a situation where even a mild hyponatremia is worrisome because of a predilection for seizures with SIADH in this population. Next slide, please. So we wanted to discuss some disposition decisions in this patient group. So what I have for you is a common stem of a new patient. And depending on the situation, we wanted to think about where would be the most appropriate way, or what would be the most appropriate way of managing this patient and where should they go. And this is where I'm going to tap on our colleague, Dr. Carr here, to get his insights as well as to how he would approach this. So we have a 26-year-old woman. This is her 4th emergency room visit for abdominal pain in the last 2 years. Physical exams benign. Your investigations are negative. There is a random urine that's already been collected because you've started to think perhaps we're dealing with porphyria. the person is able to tolerate oral fluids and they are very reliable in terms of following instructions. Those two things are actually critical. In the first situation, person describes no nausea or vomiting. Their heart rate is, slightly elevated at presentation, but it went down with analgesia to 95 beats per minute. And labs are within normal limits. So you're on the spot there.
Look, if I'm thinking porphyria, you've done your job. But I can say that a 26-year-old female who, as far as we know, doesn't have a past medical history that makes her immunocompromised or predisposed to anything. She's no longer nausea, vomiting. She's had some fluid. She feels better. She's tolerating. Certainly someone I would arrange follow-up. If you've planted a seed for me, then I might send off, stay in the dark, away from sun, some tests so that someone else can follow this up. Whether that, my worry is this person's going to get referred to a gastroenterologist and not a GIM or hematologist. But that first person, I think most of my colleagues would send home. I don't 100% know if they all would work up for porphyria, to be very honest.
Yeah, and I'm hoping here it's a situation where there's repeated abdominal pain and recurrent presentations that might just make somebody think of porphyria. And if you have, I agree with you. This is somebody you can advise them to take actually some oral glucose and have them arrange a outpatient follow-up for the porphyria testing results. And they can actually be managed outside of the emergency room and without hospitalization. Mike, did you have anything to add to that?
No, just I totally agree. And many patients who know they have porphyria will self-manage like mild attacks like this at home without presenting. They'll kind of oral glucose load. Just as an aside, a side comment, but we're talking about a new diagnosis here.
The new diagnosis, is such a different animal here. I think, Michael and Aditi, you probably realize you guys have maybe 100 patients at your hospital, 50 to 100 that have it. These people know more about the disease than the emergency doctor, and probably most people in your hospital, except maybe a couple of hematologists. So they come in with a piece of paper and says, I have porphyria, here's my recipe, do this. And we order a drug or ask our ED pharmacist for some drug that we've never heard of, like Hematin or whatever. And that's the pathway. I think the real challenge is in how to, in that 26-year-old who comes in multiple times, I think we need to get them to someone else to at least consider it, provided they're stable. And I think we may not, if we're really smart, we'll send that test for someone to follow. But I think it's just about that orphan patient who doesn't have a diagnosis. That's what Rare Disease Day is about.
Agree. And if you have a GIM rapid clinic, which we're lucky to have at St. Mike's, that's the kind of follow-up I would probably want to arrange for this person. Taking a slightly different look at the same stem is somebody else who has no nausea or vomiting, but they happen to have a blood pressure that is elevated at 171/105. Slightly tachycardic, not uncommon in somebody experiencing pain, of course, which gets reduced to 155/90 with a heart rate of 105 after analgesia. So labs are still normal. Would you change your approach here?
I think you've presented like the gray patient, the patient who's on the fence. You have to understand, to a hematologist, the blood pressure of 155/90 or 171/105, like look at my waiting room. Everyone's hypertensive because they've just waited 5 hours to see me. The blood pressure 155/90 is not going to trigger it. And 105 is certainly not 115. It would be looking at their coping skills. Probably, that where this might come in is like your judgment of the patient. Like, if this person has a real psychiatric flare or a real difficult flare, he or she, more likely she, based on the predominance in females, may not get admitted, but hopefully will at least more likely to get referrals. And the issue is what analgesia are given. And I think what you have to realize is when you're giving narcotics to patient with repeated pain, like what are you doing? Like, what are you actually treating? And you have to ask yourself, if you find yourself as an emergency doctor giving narcotics to this person, what are you missing?
Spot on. And here's a third flavor of this is somebody with persistent nausea, despite receiving ondansetron. Their heart rate has come down just fine, but now the labs show a sodium that's dropping. A bit of an easier approach here, I hope. But again, Mike and David, let me know what you think about this situation.
I mean, I'll speak for the Emerge doc. We believe that there's a god of sodium, and that god of sodium was designed purely for us to make easy referrals to internal medicine without pushing back. The problem when I pray to this god is 130 isn't usually get anyone excited. You got their heart rate back. 130. I mean, I don't love the trend, but maybe they just got the wrong fluid. And maybe you diluted them or something like that. The persistent nausea, I have to be honest, and I'm sure there's people on this call because I'm getting some texts from friends who are listening. None of these make me super nervous because 130 and someone puking or having GI symptoms is pretty common. And it makes me afraid because I feel like there's some of us who are going to send all these 3 people home, to be honest, if they look okay.
Yeah.
I'm
Yeah,
being
and I
honest.
recognize that. And I think that's the real challenge. Now, an individual with porphyria, that sodium isn't the same as having somebody else with a sodium that low, given their predisposition for seizures and so forth. Um, but this is the challenge. This is why it is incredibly difficult to actually get that person diagnosed. And there's so much pushback in terms of, like you recognized, a lot of other people that you talk to or call for help may not take this seriously because we've seen this so many times, it's usually nothing, right? So I think this is the person where we need to be a bit more stronger in our advocacy and getting them assessed faster, perhaps in the hospital. And that's really a challenge.
I mean, it's too bad they're not febrile because that would make things easier. We tend to get afraid of fever, and then maybe we would punt that elsewhere. But I think this really highlights such a key point when you're saying it takes 15 years to delay diagnosis. I think everyone on this call who's an emergency doctor has contributed there because you've presented 3 cases that are freaking you out, and I'm not freaked. It makes me nervous. I think if we're missing this diagnosis, at least getting follow-up and maybe ordering the test or suspecting it, or even saying to medicine on the referral in a rapid clinic, one could consider a porphyria workup if you're afraid to order it and pull the trigger. Plant the seed.
Yeah, just about the sodium, I just wanted to add also that like part of the reason we get worried about it is like one of the mainstays of treatment, the first line treatment is you're giving them like D10, but that can of course exacerbate the hyponatremia. So that's someone we would want to monitor.
Thank you. Next slide. Oh, here we go, Mike.
Yeah, so this is something so we alluded to this earlier, the concept of kind of care plans, so that we're now shifting away from someone who's an undifferentiated patient who you're thinking about porphyria to someone who actually has a known diagnosis of porphyria, because this is the other way they may present to you in your emerge. There are a new recently published guidelines from the I forgot the journal it was in, but Canadian consensus guidelines on management of acute hepatic porphyria, and they advocated for use of care plans to kind of communicate and allow the patient to inform people of their diagnosis when they're coming in. We do this with our bleeding disorder patients too. As I've shown here, like this is straight from the same patient that we presented earlier. This is from her care plan. But what I was interested in is having a discussion or getting some thoughts as to like as you are the receiving end of these, like what's actually helpful and to have in this document that the patient's bringing in with them or pulling up on their phone when they're in your department. So we have this, menti.com. If you can type in things that you think should be included in a written care plan for someone with acute hepatic porphyria, I think it's going to generate a word cloud for us and we can kind of see what people think.
Can I start by writing yours and Aditi's cell phone number as one of the options?
Yeah.
No, I mean, I think the phone a friend
Yeah.
option is really helpful. I'm teasing obviously on a personal level, but at UHN we have a big metabolics program, and those are during daytime hours or even off service. Like knowing that I can call someone who has that specialized knowledge is really helpful. And then to keeping it very simple, and the other thing is sometimes the drugs that you want are not easy for us to get. So maybe an understanding of you will want this, you'll need to call the hospital pharmacist or how to even speak to the right person. And I work at Toronto General and Toronto Western. A lot of people on this call are not working in quaternary care centers. So what's the mechanism if you're working in Iroquois Falls, if you're working in Kapuskasing, of getting someone treated, because there's no way they're carrying that drug. So how do we do it?
Absolutely. And this is where I want to emphasize this is a blood product. Hemin is a blood product. The person you're calling is actually a blood bank, which is also a little tricky when you think of treatment medication, right? So you're calling your blood bank, you're calling your hematologist or your transfusion doc who'll be able to procure this drug for you with your assistance as well in terms of the timing that it's needed, or our consultants. But we will go through it through our blood bank, through ordering it from Canadian Blood Services.
Yeah, this is great. So I see investigations that may be needed, typical starting fluids, the contact information, phone a friend, triggers for admission. This is very helpful for me. Can we maybe go back to the previous slide? So I'm going to look now and see what we actually have. So it kind of talks about here kind of how they might be presenting with an attack, triggers, the link to the drug database, and then it's kind of management advice. Again, this is someone who has a known diagnosis, so it's about the treatment. So we have here kind of medications that can be given, common ones that are commonly like Buscopan or Gravel, which are not safe in porphyria. So I specifically mentioned them just to, because otherwise there's a high chance they will be given. I do have the suggested starting rate of the fluid here. Suggested to monitor electrolytes and the sodium. I admit, so it's helpful to know that. So yeah, so people were asking about specific information on how to get penhematin. Here, so we're actually at St. Mike's. We're happy to take these calls from anywhere in Ontario. If you have a patient coming in, like you can call us, reach us through St. Mike's Hospital locating, and we can give advice. But maybe I could add a little bit more information here about actually accessing penhematin. So that's helpful feedback for me. And then I do have the phone a friend information there. So the St. Mike's Hospital locating number and how to contact us. Though of course, if you're somewhere that has your own in-house hematologist, always good to get them involved too, to have someone on site. But we're happy to also provide kind of tertiary care level advice. Okay. So these we're pretty much we're doing well for time. So these were the main things we wanted to take home, or you to take home today. So it's a rare disease. Porphyria, acute hepatic porphyria is a rare disease, but someone has to think of it for the diagnosis to be made at all. And that's not going to, no one's going to walk in and see a hematologist with abdominal pain. So it's going to be you or an internist, a hospital. It's like it's a general practitioner of some kind or a generalist that's going to be making this diagnosis. So that's you. Hopefully we've shown that the kind of initial approach to diagnosis is actually more straightforward than you might have thought. It's a single test. It's some nuances around how to get that test done properly, but it is a single test, that random spot you're in. Think about triggers that may have prompted them to come into your emerge, especially if it's whether it be a new diagnosis you're thinking of porphyria or someone with existing porphyria that's coming in with an attack. there's very little downside to starting empiric carbohydrate loading if you have a high suspicion for the diagnosis. It gets sugar water, like so start someone on that D10 infusion while you're kind of waiting for referral or admission or further advice or potentially panhematin. And then Heman's available for a confirmed diagnosis of acute attacks. So we do occasionally use it in someone without a confirmed diagnosis if we have very high suspicion. But that would probably be best discussed with the specialist hematologist or whoever it is at your center that would be managing. But knowing that if Heman exists and how to access it is what we wanted to kind of impart upon you today.
Michael, could I say something?
Yeah.
It's crazy, these stats, 15% year delay to diagnosis. You have 20% long-term disability. Have you ever studied, or is it studied? If you say this is, I think 4 or 5 times more common in females, and knowing the average age, if you look at women with a diagnosis of chronic pelvic pain with endometriosis, what percentage of that subset do you suspect has a code disorder or maybe a missed disorder of porphyria? Because I can tell you how many young women with cyclical abdominal pain get just labeled, it's your period, it's dysmenorrhea, it's your endos flaring up. Like, there must be such incredible overlap in that population.
Yeah, I admit I don't have an exact number in mind. Aditi, do you know if anyone's looked at that or published on this? I'm sure it has been, but
There's not a lot of good data on that select population, and I think that's a great idea. I think we need more information on this.
Just send urine screens on everyone in a gynecology clinic and see what you hit. I don't know. It sounds like an interesting CIHR grant, but I mean, I feel like that's a group that we're really underdiagnosed in, is women with chronic abdominal pain, chronic pelvic pain. They have hormonal triggers and everyone just says it's your menstruation, get over it. And I think that's a terrible way that medicine's practiced.
Unfortunately, that does happen to people. The part of the menstrual cycle where you're going to see that progesterone rise is actually ovulation. So interestingly, these folks will not present at the start of their bleeding, but rather at ovulation, which is an interesting correlate if you happen to delve into that while looking at the history.
There's a question in the chat about will all hospital labs run the urine spot test? No, but your lab, wherever you're working, should have a pathway where they have somewhere, like a reference lab, that they can send that specimen out to get the testing done. So the best thing to do would be just talk with your lab and tell them that this is what you're thinking of, and hopefully they know which reference lab they use. Like even for St. Mike's, at St. Mike's we send it to Ottawa, I believe. So even our hospital is not done in-house. If you're really stuck or you're working somewhere really remote and they have no clue what to do with this, like what we've done in the past is you can call us at St. Mike's, and we're happy to take the specimen. You can send the specimen to our lab, and then we will process it and get it out to the appropriate place if the place you're working is not sure where to direct it.
I may chime in with more questions because I'm super curious and people might be shy, but obviously this is a diagnosis of many faces and many mimics. I think, Michael, you alluded to people having their gallbladder out, their uterus out, their appendix out, all these things that aren't obviously solving the problem. And then someone probably pieces it together and says, okay, it's not biliary colic, it's not endometriosis, it's something else. One of the coolest things I thought about, and I'm someone who thinks about associations, is that person with a GI illness who now has some ascending weakness or just feels very weak, and someone starts to think about GBS. And I think that's really cool because I've suspected GBS a lot in my career, and I haven't suspected porphyria, although I promise I'm going to change. Can you tell me about the person that the neurology or the emerge doc thinks about GBS, where you might want to think about porphyria? I imagine you don't get GBS every month. So if you're getting a cyclical GBS or it keeps happening to you, it's probably not GBS. But maybe there's something clinically there that when you suspect that weakness, Because as we all know, GBS can have a Campylobacter or some sort of GI start to it that triggers it. But where's the overlap that may help clinicians if they think one?
I'll say that with the abdominal pain, constipation is more common than diarrhea. In general, with your GBS folks, you're going to have a previous history of diarrhea. Again, like you alluded to, that recurrent presentation becomes an important key piece. Also, maybe it started after dieting, maybe it started after alcohol, maybe it started after puberty. So those are the kinds of things to harp in on in terms of the types of things that can help you clue you in. And we don't see GBS every day necessarily. I provide therapeutic apheresis as well, but definitely far more commonly than porphyria. When I receive the patients, do I send off porphyria screening on many of them? I have to admit, I get referred quite a few GBS when I'm treating as therapeutic apheresis doc. And I have sent a couple of porphyria screens, and so far I am at zero diagnoses, but I have in some situations where I've had some interesting things on their history that have made me worried. So the hit rate isn't as high in terms of getting that diagnosis as I would like, but I really acknowledge the what you're putting together here in terms of associations, and I think that is important. The other piece is autonomic instability is also common in GBS. So that's the other piece that you might see. And bladder dysfunction, those two findings can also be found in porphyria. So don't let that deter you from sending a screen.
What I wanted to know, and obviously I did some reading because I wasn't about to get on a national grand rounds and know nothing about porphyria apart from my med school internal medicine days when I was a resident. Genetics. We talked a bit about, I've read it could be autosomal dominant. How helpful is like my dad or my brother or my sister, my mom, they all have the same problem. Like how important should that be when I see someone with cyclical abdominal pain? You know, I've always thought about things like in people with familiar Mediterranean fever or Behçet's or things where there's certain ethnicities, but how in the cyclical abdominal pain person, how important is family history?
Yeah, it's a good question. I like in my 2 years of experience as a porphyria doctor so far, I have there certainly are some families where it's known that there is if you ask more questions, it's like so and so always had abdominal pain or died of liver cancer. That's like there's an association with HCC we didn't talk about. And like there's never really a clear diagnosis. So but it's tricky because some of these symptoms are maybe someone just thought their mother had endometriosis when really it was porphyria all along. So the reason that I'm glad you brought up genetic testing though, because it's worth mentioning the reason that genetic testing is not first line for diagnosing is the rate of actually having a mutation is an order of magnitude higher than actually getting clinical disease. So the penetrance is only about 10%. So if you're doing if you were to do genetic testing first or send genetic testing first, I don't think anyone is going to be sending genetic testing out of the emerge, but it can actually lead you astray because you might find a mutation and actually that's not what's causing their symptom because it's just they have a mutation, but there's some other reason for their symptomatology. So it can it's really a biochemical diagnosis.
So I guess having somebody with a family history of these recurrent things happening in their family every generation, even if it wasn't labeled porphyria, because that label is hard to get, helpful if it's present, not helpful if it's absent.
Okay, so I'm mindful of the fact that we have just about a minute left. It's been an incredible topic, and I think you've opened the ears and the eyes to a lot of people. And if I had to summarize, I think the first thing as emergency physician is the person's going to come in with cyclical or recurrent abdominal pain. The person is most likely going to be female. Their vital signs, albeit will be labeled by Aditi or Michael as autonomic instability, but you might not freak out about them because they're not that terrible. Their sodium will be low and you won't really care because it's not that terrible and you can't refer to medicine based on that alone. But if you take an excellent history and you get a sense that they are having this problem recurrently, maybe it's hormonally, maybe it's diet, maybe there's some trigger, maybe their sister has it, maybe their mom also has problems, plant the seed that maybe that person doesn't need to be referred to GI for an endoscopy and colonoscopy. They probably already had them and it's normal. That maybe since hematology doesn't probably want to see them with abdominal pain until they have the tests, but maybe you should think about ordering the test, or at least maybe you should think about planting the seed to GIM when you make the referral of a young 40-year-old female with recurrent abdominal pains centering around with their luteal phase, who's constipated, has been scoped and everything's normal. I don't have a clue what is wrong with them. Maybe you should consider porphyria.
That's an excellent summary. Thank you.
Guys, it's been amazing to have two experts on this call. We really appreciate it from Cape having you join us. Thanks to everyone. And the first person who makes this diagnosis, please text me so I can let Michael and Aditi know. Thanks for everyone for your time.